A lot of controversy surrounding statins. Let's take a look why. Okay, so I'm going to react to this video, which is by Dr. Ken Berry, a physician, which has a video titled Statin Depression, Truth About Cholesterol Medications. I'm sure this won't be biased at all, but let's take a look.
You know, statins that are supposed to lower your cholesterol and protect you from heart attack, stroke, dying. Turns out that's all bullcrap.
Okay, we have this study here, which included 62 trials involving 120,000 patients. The study concluded for primary prevention of cardiovascular disease, the risk of adverse events attributable to statins was low and did not outweigh their efficacy in preventing cardiovascular disease, suggesting that the benefit to harm balance of statins is generally favorable. Now, there's also this study, which included 19 trials involving 71,344 patients. In adults at increased CVD risks but without prior CVD events, statin therapy was associated with reduced risk of all-cause and cardiovascular mortality and cardiovascular disease events with greater absolute benefits in patients at greater baseline risk. How about this study with 21 trials full of 184,000 patients showing 12% reduction in major cardiovascular events after 1 year, 20% after 3 years, 23% after 5 years, and 29% after 7 years. So they probably work.
So this new study was published in JAMA's Internal Medicine Journal in mid-March of 2022. What you may not know is that a lot of statin companies, they fund their own research, but then they also keep the results private. They do not share the results.
A drug company funding their own medication is very, very common practice. And the reason for that is because it doesn't make sense for someone else to fund my study because I'm the one that has to prove if this medication works or not. You're not going to give me $10 million on a whim and be like, let's see if your drug works. So a drug company funding their own research is pretty common practice, and if this guy thinks that that's unethical or immoral or anything like that, then he must not prescribe any medications because 99.99% of medications are funded by the drug company themselves. That's why the drugs are so expensive. It costs pennies to manufacture the drug, but it costs millions to fund the research to prove that it works.
These researchers found that there was no consistent relationship between lowering LDL-C with a statin and your risk of death, heart attack, or stroke. Yeah, no consistent relationship.
But there is a relationship between lowering LDL and reducing stroke, myocardial infarction, which is a heart attack, and death. There is a relationship there, and that's mostly because of ApoB and not really LDL. But LDL and ApoB usually go hand in hand. So if you lower LDL, you're going to lower ApoB, you're going to lower cardiovascular events.
Now you see these tall, light gray bars on the graph. These are the relative risk reduction. And so for overall mortality, your risk of dying, statins reduce it by 9%. Myocardial infarction, a heart attack, they reduce it by 29%. And then for stroke, they reduce your relative risk by 14%. Look at the very tiny little bars. So for mortality, we're talking about an absolute risk reduction of 0.8%. For heart attack, it's 1.3%. Or for stroke, it turns out to be 0.4% absolute risk reduction.
Okay, let's go over absolute risk reduction versus relative risk reduction and which one matters, which one's better, so and so. And I'll do this by giving an example. Now, let's say I wanted to do a study on death rates. How many people die by a certain age? If I stop my study after 5 years, how many newborns do you think are dead by the age of 5? A very, very small percentage. Maybe 1% of newborns are dead by the age of 5 because of, an accident or a genetic defect or something to that nature, right? 1% of newborns don't make it to the age of 5. Now, let's say I have this new drug, this immortality drug that gets rid of all those deaths. So nobody dies by the age of 5. 100% success rate. Every newborn lives until the age of 5. So absolute risk reduction is the literal difference in the percentages. So 1% of babies that died versus 0% that died. So 1 minus 0 is 1%. My relative risk reduction is the percentage that was reduced between the two groups. So in this case, it's a 100% reduction because I got rid of all deaths. Nobody died. Now imagine I follow these newborns until they were 100 years old. 99.99% of people die by the time they hit 100 years old. So my death rate is about 99.99%. Let's say I still have this miracle drug and nobody dies, 100% success rate. So my relative risk reduction is still 100%, right? Because I prevented all deaths from occurring. But in this case, my absolute risk reduction is 99.99%. What was the difference? It was the length of my study. The longer I followed them, the better my drug looks, right? In terms of absolute risk reduction. It looks the same with relative risk reduction, but according to this guy, that's irrelevant. Absolute risk reduction shows a massive benefit after 100 years. Almost 100% difference because I prevented all deaths. But when I stopped at 5 years, it only showed a 1% success. And that's because I stopped it too early. There's not enough people dying after 5 years old for my drug to show absolute risk reduction benefit. So it's the same logic with statins. A 36% reduction is relative risk reduction. Someone that's 23 years old and gets put on a statin is not going to show absolute risk reduction benefit because they're not going to get a heart attack in the next 10 years probably. The chance of that happening is very, very small. But over the course of this guy's 40 years, his chance of a heart attack with high levels of LDL and ApoB are very high. But to follow enough 20 or 25 or 30 years old on statins for a longer period of time and a high enough participant number to be able to do this for 40 years is extremely expensive. So you use relative risk reduction to show, hey, this works, and it's probably going to be extrapolated for the long term. So you have to do these studies for an extended long period of time to know the true benefit in terms of absolute risk reduction. That's where there's a flaw in his logic. It shows relative risk reduction because it works. It doesn't show absolute risk reduction because they're not being followed for a long enough period, 25, 30, 40 years.
Now, keep in mind that by taking a statin drug every single day, you're going to be lowering your testosterone level. You're going to be raising your blood sugar levels. You're going to be lowering your levels of coenzyme Q10, and you're going to be increasing your risk of having severe muscle aches, even muscle breakdown, liver damage, and a whole host of other side effects.
Okay, now the side effects he's listing are pretty well-known side effects of statins. In terms of muscle wasting and muscle damage, if you just change the statin, most of the time that goes away. Liver enzymes, just like any other medication or any other thing you do, you just monitor it and you make sure it doesn't get too high or too damaged. In terms of blood glucose, it increases A1C by around 0.5%. So if you're hovering around pre-diabetes, it might push you to diabetes, which obviously nobody wants. But you can just kind of, watch what you're eating as well and kind of get out of that pre-diabetes stage and be able to lower your diabetes through lifestyle modifications or take anti-diabetic medications if it gets too bad, or just get off the statin and let it come back down by 0.5%. None of these are life-threatening, irreversible side effects. I'm not a fan of fear-mongering side effects before you even take a medication. Majority of these people don't have any of these side effects, and most people that do are kind of already predisposed or have something else that's kind of causing that side effect to occur. This would be like me telling you don't eat peanuts because there's people out there with a peanut allergy and they have anaphylaxis and they can't breathe. Yeah, but I don't have a peanut allergy, so why can't I eat peanuts? It's the same concept here. You may or may not have these side effects.
That's why I encourage you to print out this new article and take it to your doctor at the next visit. When your doctor tries to give you a statin, I want you to say, is it really worth all the side effects for me to reduce my risk by potentially 1%?
Again, you don't know if you'll experience all or even any of those side effects.
So I think the time has come to tell it like it is and say, unless you have had a previous heart attack, a documented heart attack, so then you would be taking a statin drug for secondary prevention.
Why is he okay with statins for secondary prevention? Those same studies that show benefit for secondary prevention are from the drug company themselves. They made the same exact study.
Safely throw your Lipitor, Crestor, Zocor, Livalo in the garbage.
Now, lifestyle modifications such as a healthy diet and exercise are always going to be number one choice. That should always be the first thing you try for any disease, whether it's diabetes or cholesterol or arthritis or whatever. Lifestyle modifications and exercise should greatly reduce your risk. But if your levels are not able to come down to an acceptable amount and medication is your next choice, I myself am not against statin therapy for primary prevention or secondary prevention. And the majority of pharmacists, primary care physicians, and cardiologists are all on the same page. Statins have benefit. Now let's read some comments. About 20 years ago, a doctor who was about to retire said my cholesterol was high and I could consider taking a statin. He then told me about the side effects and I decided not to go on them. I'm 67 now, cholesterol is still high, but I'm doing fine. Great. No one is saying that if you have high LDL, you will have a heart attack if you don't take a statin. Nobody's saying that. It's just that your risk is higher. And the longer you keep your LDL elevated without being on a statin or without being on LDL lowering medication, your risk increases. But just because you don't have one at 67 years old doesn't mean you won't get one at 75 years old. Someone that's been smoking for 20 years isn't guaranteed to get lung cancer. Their risk is just much higher than someone who's never smoked a day in their life. They both could get lung cancer. They both could not get lung cancer. But if I had to make a bet on who's going to get lung cancer, I'm picking the guy that smokes. My mom is 92 years old and they put her on a statin. I have a hard time believing that a board certified physician is putting a 92-year-old woman on a statin for the first time in her life. That's not at the fault of statins, that's just a bad doctor. I was prescribed a statin after I had a heart attack. After about a week, I started to experience muscle pain and fatigue. I scheduled an appointment to see my cardiologist and told her what was going on. She said it can't be the statins, it must be something else. Again, these are not reasons to not take statins. These are reasons to change doctors. I have a very hard time believing that a board certified cardiologist whose primary medication that they probably prescribe every single day of their life, majority of their patients, if not all of them, are on a statin, that they are unaware that it can cause muscle pain. This is a very well-known side effect of statins. Inflammation is the problem. Statins do nothing for that. What? Statins are anti-inflammatory. LDL and inflammation are greatly correlated. So by reducing LDL, you reduce inflammation. That's the whole basis of how they work. Also, they directly decrease CRP, which is a lab biomarker for inflammation. So it definitely does do something for inflammation. Now, if you guys are hell-bent on not taking a statin, you want to try lifestyle modifications, exercise, great. If your next choice is I want to take a natural supplement before I even consider a statin, I have a video on red yeast rice and its effects on lowering cholesterol. So you can check out that video.